All right, good morning. Thanks for the engineering folks for finding a different location, and for the clinical folks for sharing your space with the Cleveland FES Center for a morning. So my name is Cameron McIntyre. I'm associated with the Cleveland FES Center, which is a group of collaborative investigators around Cleveland that focus on electrical stimulation technology. And this is a joint seminar now then with Neurology Grand Rounds and the Cleveland FES Center. So today we are going to hear from Nader Pouratian, and he is a functional neurosurgeon at UCLA with expertise in deep brain stimulation and peripheral nerve surgery. Nader did his undergrad at UCLA and then went on to the MSTP program at UCLA. And then he did his neurosurgery residency at University of Virginia and then a stereotactic functional fellowship at Virginia. Is that right? Yeah. And then moved back to UCLA. Probably been on faculty there for 4 or 5 years? 5 years. 5 years, yeah. And he has developed a really exciting research program focused on using advanced imaging technology to assist in surgical navigation and surgical targeting. And I think that we're going to hear a good bit about that today.
So thank you very much for inviting me to speak, and for all of you coming in to listen this morning. As Cameron said, my background is in imaging, and what I saw as an opportunity when I started my faculty appointment was to really bridge a gap between the basic sciences and what was going on in the imaging world, so the types of things that we see at the human brain mapping meetings, and what is going on in clinical neurosurgery. And there's a huge gap. And as much as neurosurgeons think that we are on the cutting edge in terms of technology, I think there is a huge gap between what's going on in the imaging world and the clinical world, and that's where I try to close that gap. The other opportunity that I've generally recognized is that, and what motivated me to go into neurosurgery was that the operating room is basically an experimental lab for me and for others who wish to do that, that no one else in the world has an opportunity to take advantage of unless you work with a neurosurgeon. And so I somewhat feel an obligation to take advantage of that to try and help advance our understanding of disease as well as our treatments of disease. So I'll move forward. So I have no disclosures. So for this talk, what I want to do is frame this in the context of where we are in the field of neuromodulation, and identify factors that I think have contributed to the failure of several recent trials for neuromodulation, especially invasive neuromodulatory trials. Then move forward towards understanding how neuroimaging can be used to define the connectivity basis of neuromodulation, which is very similar to the work that Cameron's been doing. And then finally, identify the neurosurgical opportunities to define this network basis of therapeutic neuromodulation as well as disease. And this audience doesn't really need to see this, but it's a really important field because neurologic and psychiatric disease are one of the leading causes of disability and lost productivity. This is from the WHO. And unfortunately, the laser pointer doesn't work. But unfortunately, we don't have great therapies for many of these treatments. Thank you. Thanks. So there aren't great therapies for these, and I think it's frustrating for patients as well as physicians who are trying to come up with therapies. So we've seen clinical trials for dementia, which is in progress. Parkinson's disease, we have good therapies in neuromodulation, but these are things that we'd like to try and improve patients' quality of life. And so I think the goals of a program or the field of neuromodulation is really to improve quality of life, which as a neurosurgeon is, I think, refreshing, because otherwise we are dealing with people who are near end of life oftentimes. I think a real important goal in where we can really use imaging and connectivity-based approaches is to develop patient-specific therapies. And I'll explain how we can do that. And then finally, in today's healthcare environment, really try and develop methods to improve the efficacy, efficiency, and the cost of care. So if we can find ways to use imaging or other connectivity measures to accelerate the care that we deliver without compromising on care and perhaps improving the quality, that would be ideal. So this is where we stand right now. In neuromodulation, these are the core things, modalities that we have available to us, which is spinal cord stimulation, deep brain stimulation, intrathecal pumps, with some of the applications. You know, one way of expanding it is to expand these therapies, which is where most of us put our time into it. So using spinal cord stimulation for other applications like spinal cord injury, deep brain stimulation for new diagnoses like post-traumatic stress disorder, which we have a protocol at UCLA, pain, minimally conscious state or disorders of consciousness, and then other potential applications as well. But we have to recognize the field of neuromodulation really isn't just electrical modulation. And so these are all technically can fit into the domain of neuromodulation. We have to figure out how they all fit together. But of course, today I'm going to be focusing on deep brain stimulation because that's what I do and that's where my research is in. And it's the idea that you've got this very complex circuit and it's simplified in a cartoon, and we put electrodes in a certain place and we hope to modulate a very specific target, theoretically without affecting other fibers near it or affecting them in the correct way in order to achieve an outcome. And the reason why we do this is, and the reason why deep brain stimulation is favored as opposed to lesioning, is that it's reversible, it's modulatable. It also, from a scientific standpoint, is very interesting because then you can tweak things and try and understand the system by perturbing it in different ways. Although, as a side note, I think, as we had a discussion over dinner last night, lesioning is still a very good therapy. It's still available, and there's a little bit of a resurgent interest in lesioning, although that's for another talk. So in terms of deep brain stimulation therapy, the therapies that we have, for Parkinson's disease, I think we have to take a close look at Parkinson's disease because it works. It's one of the only very well proven therapies or diseases for which deep brain stimulation works. This is from one of the trials that's looked at how patients change with time with deep brain stimulation when they're randomized to medical therapy versus neurostimulation. And you can see after 6 months of best medical therapy, this is their daily diary and how much of the day they spend in different conditions. There's no big change, but with deep brain stimulation, there's a significant change. They spend more of their day in their best on condition. They have decreased off time, and they have decreased troublesome dyskinesia. So we have a therapy that works, and everyone, I think we're very interested in characterizing that further, but we take it for granted why it works, and I want to get into that a little bit more. On the flip side, we have neuromodulatory trials that have failed, one after another. So besides Parkinson's disease, we really haven't had a successful invasive neuromodulation trial in a very long time. So there was a motor cortex stimulation for stroke recovery, which was a complete failure. The group that received stimulation versus a group that didn't did exactly the same on a population level. So no good outcomes there. Deep brain stimulation for depression. Now we've had really 2 trials that have not continued. There's the ventral capsule, ventral striatum area, and now Area 25, which is sponsored by another company. Which has also halted for based on futility analysis. So what are the differences here? So why do I think that those trials have failed? So stroke and depression have both failed. Now there's other therapies that are under investigation, and I think there's a fair chance of failure. And if you talk to people in the field, they're concerned about failure. These are what I think are the potential causes. So heterogeneous populations. You're dealing with depression, you're dealing with stroke. No stroke is exactly the same, and in the stroke trial, they included all different kinds of strokes. So they included subcortical strokes, they included larger hemispheric strokes, they included basal ganglia. There was no real selection criteria besides stroke. which you'd expect in a trial like that, with a uniform therapy that's just putting an electrode over the motor cortex, that you're not going to get a significant outcome. The patient population isn't going to allow it. Depression, the same thing. If we look at the criteria for diagnosing depression, there are many, many criteria, and there's different variants of depression. And if you treat everyone with different kinds of depression with the same therapy, it's not terribly surprising that it's not going to necessarily work or be very effective. Imprecise targeting. So we know in deep brain stimulation that location is everything. And so we need methods to improve our targeting on a patient-specific basis. So that could be higher resolution imaging. It could be using patient-specific advanced imaging, like connectivity-based imaging, to target different methods. And I'll get into why that's important in a moment. And then suboptimal stimulation paradigms. We don't really understand, especially for these newer diseases, how to stimulate the brain or what the optimal stimulation paradigm is, so we need to understand that better. So the really question is, should we be continuing doing trials the way we're doing it? And I would argue that, if we continue the same way, we're just going to continue to see failures. And I'm going to go back to Parkinson's disease in a moment to really to highlight why what the critical differences might be. So I do think we need better methods. We need physiological biomarkers and not just symptoms. So this is from another talk that I give when I just talk to neurologists who don't know much about deep brain stimulation and what they need to think about when we're thinking about patients for deep brain stimulation. And so, the first two criteria, diagnosis of idiopathic Parkinson's disease. So we want a very homogeneous population. We want people who are Cinemet responsive. All right, we want intact cognitive function, an age-appropriate brain MRI, which basically what we're saying is we want to be able to see what we are targeting in the brain, and then medically suitable for surgery. And if we translate all this, into what they actually mean, we're trying to optimize patient selection over and over and over again, and then we're trying to optimize surgical targeting. The critical factor here is we have a physiological biomarker of who's going to respond to deep brain stimulation for Parkinson's disease. People who are levodopa responsive respond to deep brain stimulation for Parkinson's disease. It is well known, and that's how we homogenize our population, right? If someone doesn't respond to levodopa, we really generally won't do, unless there's other circumstances, which is extremely rare, we won't do deep brain stimulation for them because they probably don't have idiopathic Parkinson's disease. What I think the field is really missing is that is a critical state. We have selection criteria beyond just the clinical diagnosis. We have a physiological biomarker, and I think what we need to move towards is biomarkers for selection of patients for other neuromodulatory trials. The other issues are that of limitations of indirect and anatomic targeting. This is just to highlight, the types of numbers we use to target the different regions. And you can see this is really historic, relying on anterior commissure and posterior commissure because that's what they could see with ventriculography. And we could see how useless it really is, because if you take 452 brains and you merge them based on ACPC and you average them, that's what you get out of it. You get a blur. And so we know that patients' brains are not just ACPC based, and we need a better resolution than that. We need patient-specific maps, however we generate them. So then the goals really to improve surgical precision and therapeutic efficacy are, again, I'm emphasizing patient-specific maps. So we made a big leap in neurosurgery when we went from ventriculography to direct imaging with MRI. And I think we are now at a point with newer therapies where we were fortunate that we had a target for Parkinson's disease, but things like depression, where it's area 25, which is a white matter tract with a ventral capillary ventral striatum, we need more than just a target that we can see. So, and they have to be patient-specific. They need to be functionally pertinent. They need to be easy to obtain. So we can't get too complicated that it's not practical to spread throughout multiple centers, and easy to interpret. So a lot of what I'm going to talk about today, you're going to say that's not so easy to interpret, but once we understand them, it shouldn't be too difficult to translate them into a more practical, usable solution. So my approach, as I've already been alluding to it, is to use connectivity as a method. And I think there's ways of looking at connectivity in the brain, both anatomic and functional. And of course, this arises from this concept of the human connectome, where we've really been emphasizing connectivity in the pathophysiological pathoetiology of disease. So diffusion tractography gives us a way to measure structural connectivity in the brain. We have functional methods as well, so you can look at electrical signals, coherence of signals, as well as cross-frequency coupling. But you can also look at not just electrical, but resting state fMRI. And I think once we start to put all these methods together, we start to understand disease better, but we also start to understand our therapy better. And the neurosurgical implications are that we can understand our interventions and target our interventions based on these therapies. Now, pulling on other people's work besides my own, and this is from Cameron's work. This is why it's important. This is why I think connectivity is important. So this is an analysis of the ventral capsule, ventral striatal area, and this is from, I believe, non-human primates looking at tracts in the actual brain. It's a very complex area that you can't see anything of on a structural MRI, right? You can't see any of these tracts that are going through this region, and they're extremely adjacent to one another. So if you're trying to target a specific region, then you really need better imaging and better methods that we have. The other reasons why I think network connectivity is important, and this gets more towards patient selection. I'll use disorders of consciousness as an example here. We know that different neurological disorders or psychiatric disorders affect network level activity in the brain. And in this case, we have patients with different levels of consciousness. So locked-in syndrome, their default mode network, which is basically our resting state network in our brain, or the dominant resting state network, looks pretty much like a normal person, which is what you'd expect. They're locked in. Minimally conscious state has decreased connectivity within that network, and a vegetative state has even less. So you can imagine how we might be able to use this to start categorizing people or stratifying people for studies. But it also tells us, again, there's network level dysfunction. It's not a specific region of the brain. So disorders of consciousness are not solely a thalamic issue. It's a default mode network issue. Continuing on with that, what we also know is that deep brain stimulation is not just modulating a single area. So these are old studies, but and I bring this up for a reason, which is that we've known for a long time that when deep brain stimulation works, and this is from the Japanese group that has done many patients with disorders of consciousness, that when you turn the stimulation on, it has widespread effects throughout the brain. So again, if we're going to think about how neuromodulation works, we need to think at the network level. And more recently, there's been a big push, and I think here as well, and you all are probably ahead of the curve in using functional MRI after deep brain stimulation to assess the effects of it. This is in animals, but now that's being done in humans. So my point here being, we know that there's a lot of information to be had from these connectivity measures. We've been ignoring them, but they're probably actually really critical for how we guide our therapy and how we target our therapy. Going towards a larger view of brain mapping signals, there's a lot of bias in this field. So there's some people that are single unit advocates, and that's all they care about, and they think that nothing else is really important. And then you can get broader and broader, so you can feel potential, so from the deep brain areas, ECOG and EEG signals, and then hemodynamic signals. And of course, the further out you get, the lower your resolution, so you get more and more spatial resolution or spatial sampling, but there's decreased risk here. So this is where I started my work originally, and we closing in to higher resolution, but of course more risk, but it tells us different pieces of information. But as neurosurgeons, we have our best opportunity to do that, and we have a long history of using our invasive recordings to understand brain function with externalized electrodes or during surgery, and I think that's where we can really make an impact. Okay, so that's my rationale for how we get to what we do. So when I started all this, one of the first things I did was, I was an imager, and I happened to be a neurosurgeon, and I said, well, can we use the imaging environment, can we use the intraoperative environment to validate what we do with imaging? And so diffusion tractography has been used for years, 15 years, but with not much electrophysiological validation. And so we happened to, this was part of a protocol that we had at the University of Virginia, in which we had patients who had thalamic depth electrodes as part of another study, but also had cortical strips. And we did somatosensory-evoked potentials on these patients to see how signals evolve through the spinal, through the ascending tracts from the spine to the thalamus to the brain. And everyone knows, or everyone suspects, based on the EEG signal or the evoked potentials that record, that there are thalamic signals. And of course, we did actually record thalamic signals through these depth electrodes, as we would expect. But the more interesting thing is if we segment the thalamus, and I'm going to get more into this in subsequent slides, but if we look at the part of the thalamus that has the highest connectivity to the precentral and postcentral gyrus, which is in this region, it predicts with very high accuracy where you get those phase reversals in the thalamus. So this is one of the very first direct physiological validations that when you segment the thalamus using tractography, it's actually electrophysiologically valid, and it can help you predict where you expect your electrode, where you expect the sensory thalamus or VPL to be. Using the same patient population, where we have cortical and thalamic electrodes, we said, well, this is actually another great opportunity to understand how the thalamus and cortex interact. So everyone, probably in the earliest days of learning about the thalamus, we learned it as a relay station, that it just relays information to the cortex. We know that's not true. But now we think that the thalamus may be more of a coordinating center, that it might be sending signals and sort of serving a role in the binding theory, trying to coordinate signals between different parts of the brain. And so we have a lot of signals here. We're recording directly from thalamus and the cortex. And we were interested in this concept of cross-frequency coupling, where a lower frequency signal could be modulating the amplitude of a higher frequency signal. And I don't want to get too much into the math of it. Those of you who know it will know what it is, and those of you who don't, just know that what you see are one frequency of the field potential signals are modulating the amplitude of another frequency, and it's a sign of coupling across different bands of the signal. So we said, and my theory going to my hypothesis was that cross-frequency coupling is actually a network phenomenon where one part of the brain is sending the signal to another part of the brain and modulating signals in the other. So in this case, the thalamus is regulating cortical activity through this mechanism. And so what we did is we looked at the cortical signals at first, and we look at the power spectrum, and we see the areas that happen to have this theta peak are the areas that we have a lot of cross-frequency coupling. So this is where these lower theta powers are modulating these beta bands. And so we said, well, that's interesting that we only see this cross-frequency coupling in the cortex where we happen to have this theta peak. Where's that theta peak coming from? And so we then looked at our thalamic signals. So if you look down at these signals and compare them with that, we said, well, the areas that happen to have very high coherence between the thalamic signals and cortical signals are the same areas that have this cross-frequency coupling in the cortex. And finally, we took it a step further, and we said, well, what if we look at how the thalamus signal or thalamic signals relate to the cortical signals? And what we found was that there's actually thalamo-cortical cross-frequency coupling, meaning that the low-frequency thalamic signals were modulating the higher frequency signals in the cortex. And this area right here, so this is where we go multimodality, trying to understand the relationships between all these, is the strength of this thalamo-cortical coupling, where we saw the thalamus regulating the cortical signals, is directly related to the probability of connectivity based on diffusion tensor imaging between the thalamic area and the cortical area. So, and we saw this coupling in different areas. So different thalamic regions coupled with different cortical areas, and it was consistent with the structural connectivity. So not only did this exist, so we had strong coupling that was structurally constrained, so the DTI predicted where it occurred. It was also temporally dynamic, meaning if we looked at these signals over time, there was a very strong correlation. So it seemed when the thalamic signal went up, the cortical signal went up, and the coupling went up as well. And so we looked at a causal analysis, and this is basically a Granger causality, where we look at, is one signal causing the other signal? And we have some causal flow from cortex to cortex. We have some within the thalamus. We see no flow from cortex to thalamus, but we do see flow from thalamus to cortex, which suggests that the thalamic flow is forward feeding to the cortex and causing these coupling relationships. So long story short is the value in this was, one, it was interesting because it actually shows the thalamo-cortical coupling and thalamic regulation of temporally dynamic cortical activity. But more importantly, it shows that that correlation with the structural imaging shows that these DTIs are actually functionally and electrophysiologically meaningful, and they can inform our understanding of physiological relationships between distant parts of the brain, and that gets us back to the neuromodulation aspect. So again, we're talking about patient selection. I'm going to go back now. How can imaging be used? One of the big points I made was that we have heterogeneous patient populations. Can we use imaging to try and stratify our patients, try and understand more about the patients that we're treating? And can imaging be used as a biomarker to classify patients? And this was a small study we did because every patient that we operate on for Parkinson's disease gets neuropsychiatric or neuropsychological testing. And it turns out because of my interests, every patient who gets an MRI for DBS also gets diffusion tensor imaging and gets resting state functional MRI. And so we have a rich database of neuropsychological data as well as diffusion tensor imaging. And we said, well, let's just do a quick and dirty analysis. Can we figure out if there's things about the fractional anisotropy, which is a measure of basically the directional flow within each voxel, is the fractional anisotropy in different regions of interest related to different cognitive measures? And in fact, that is what we found, is that different cognitive measures correlated with the FA values of the fractional anisotropy in different areas, and in areas that you might expect. So executive function was dominantly in the frontal projection fibers, the anterior corona radiata. Memory, for example, include the fornix, which wasn't terribly surprising either. And we've published this, but basically we can see that there's a lot of information to be gained just from the fractional anisotropy, and that it correlates extremely well in specific regions, and regions that you would predict to be involved in these different functions. And this is much a proof of concept that there's a lot of information in this imaging. And this is, as I said, a quick and dirty. This is almost overly simplistic because it's looking at single factors, looking at they correlate. You can imagine if you apply machine learning algorithms or other algorithms, you can easily start to separate patients based on the multimodal data that's available in this type of imaging. Again, getting back to consciousness as an example, getting to this idea of connectivity. So the idea for neuromodulation for consciousness is to stimulate the thalamus in order to restore these networks, these thalamo-cortical networks, try and increase arousal, increase interaction and function. And if this is the working model, then you would think that you'd want to have sufficient ability, or the brain should have sufficient ability to support such a restoration, right? So if this is our goal, is to restore this network activity, if someone doesn't have the ability or the structure or the function in the first place to have that restored, then they're probably not going to be good candidates for such intervention. And so I think, just to emphasize again, getting back to this idea of what's going on in the brain to begin with can be an important selection criteria. And although these people have shown, and many groups have shown, that there's some kind of correlation, groups have also shown, and this is from Martin Monti, who's at UCLA, that if you, and this wasn't done while he was at UCLA, he came right afterwards, but in this case, they put patients with disorder of consciousness in a functional MRI, and they asked them to imagine playing tennis or navigating through a house, and they looked at the signals in their brain. And of the 51 patients they looked at, 5 of them were able to willfully modulate their brain activity in ways that they didn't expect them to. So patients who they thought were unresponsive, non-interactive, were able to modulate their brain. And so again, I think this tells you that we have a lot to gain from imaging, that our diagnostic, the reason why I put this up, our diagnostic classifications, as good as we think we are, we're not that good. And so I think looking at things like this, where with willful modulation, and understanding how that relates to our, for example, resting state activity, is going to be very informative for patient selection for whether we do neuromodulation for consciousness or for depression. You can imagine the same thing. If the depressed networks are, if people have different patterns of depressed networks, they're not going to respond to the same therapy. Okay, so moving now to more towards targeting, which is the surgical component of it, which I'm obviously more interested in. When we first started doing this, I said, well, can we use connectivity measures to guide our therapy? And we did something like this where we said, okay, let's just look at the FA maps, which is interesting because it gives you some information. And one of our residents worked on this and showed that you can actually much more clearly identify the subthalamic nucleus region by using the FA maps, again, because you've got the internal capsule that has such a strong downward direction versus the subthalamic nucleus, which doesn't. So again, a lot more contrast that can be obtained from this type of imaging. But I personally have stared at these images for years now, and it's hard for me to interpret. And so I think its practical nature is not so good. And what I actually had intended when he started working on this was to do this. And this is an interesting story because I first saw this method of thalamic segmentation. So basically looking at how different regions of cortex are connected to the thalamus. I first saw this reported at a human brain mapping meeting, I think in 2001. And I remember at that time I was already interested in neurosurgery, and I thought, wow, if we can just do that for neurosurgery, that would be great. We can actually target areas. And for better or worse, no one did it until I became a faculty member at UCLA, so I did it finally when I had time to do it. So just keep your eyes open at conferences. Sometimes you'll pick up on something. So anyway, so the idea was, the thalamus has very little internal architecture. And can we segment the thalamus based on its connectivity to different regions of the brain and create a thalamic map and use that to guide our therapies? And so in this case, what we did, and there's more analysis behind it, but this is the punchline, which is that if you look at the thalamus in these 6 subjects, and you look at how it connects to the premotor region, so precentral gyrus and right in front of it, you get a certain map. And if we look at our DBS electrodes, which are in green here, sorry, it's not projecting the color extremely well, but the green area for the patients who had good responsive therapy is almost always exactly in that yellow area, the highest level of connectivity with the premotor regions. This electrode in particular had no effect on stimulation. Now that's actually, it looks like it's in a very wrong place, so it's not surprising. But this is a proof of concept that we can use this tractography-based thalamic segmentation to guide our therapy. And if we can do this, then you start thinking, well, can we use this to guide other therapies like non-invasive therapies, or can we do surgery asleep because we can just target based on the connectivity? What I did want to highlight is that these maps are very different in each subject, so it's not that you get the very similar map. And in fact, if we fuse these, if we do a registration of all the images and we look at the overlap in terms of maximal connectivity is not extremely high. So it's only 70%, and this is using a nonlinear registration. Sorry, that's using linear registration. Using nonlinear registration is a little bit better. But we've also shown, this is, again, data from the University of Virginia, where they're doing high-intensity focused ultrasound for lesioning of the thalamus. And you can see here where the lesion is exactly in the area that correlates with the part of the thalamus that has precentral connectivity. There's an excellent outcome, a very high level of tremor suppression. In this case, the target or the center of the target is distant or not right in the middle of the precentral connectivity region, and there was not a good outcome. And so I think this tells us that we've got visitors. This tells us that this is actually useful, and maybe we can use it for non-invasive imaging, although this highlights a limitation, which is that it's not everything, right? So we can have extremely high concordance, but a poorer outcome. So someone who doesn't have as good. So getting the target right is not everything. Maybe there's something about this patient's disease that was different that would go into the patient's selection criteria. Again, looking at how this can guide our therapy. So not everyone's maps look perfectly clean like the ones that we publish in our figures, but this is a good example of one. So this is how this patient's overall thalamic map turned out, but that's where the precentral gyrus connectivity is. And that's where our electrode ends. So this one is pretty much where I expect it to be, so having done this a while. It pretty much, if the electrode ends up in that vertex of maximal connectivity, it's pretty good. This one seems a little bit anterior, and I was a little surprised by that, so I went back and looked at the notes. And in this case, what had happened is, if you look, so in this case, the electrode actually was originally 2 millimeters posterior, but it was causing persistent paresthesias. And if we look at the area that's connected to the postcentral gyrus, which is our sensory cortex, that is a very tight correlation between the thalamic region with precentral and postcentral connectivity, and that's why in this case the electrode was moved anteriorly. So again, very informative in terms of how we guide our therapies. I'm going to skip that for sake of time. We've applied this to our pain population as well. So in the pain setting, we're trying to get our electrode in the sensory thalamus, which is the working model. This is off-label. I should mention that since this is, I think there's CME here. This is off-label use of deep brain stimulation. But in this case, when the electrode is in the area that is most connected to the postcentral gyrus, these people did extremely well. When it completely misses that area, those are people who are treatment failures. In this case, this is a more recent case, but an extremely satisfying, gratifying case, because in this case, we got it exactly in that area, and the sensory threshold was 0.6 volts, which is extremely low. And this patient ended up doing extremely well with her therapy. Interestingly, we've been managing her now for 1.5 years, and I thought when we got the 0.6 volts, I said, this is going to be great. She's going to do extremely well. And for 1.5 years, she said, it's not working, it's not working. And she just had spine surgery, so they turned her stimulator off. And she didn't realize how much it was helping her until she turned it off and couldn't wait to get it turned back on. And now she realizes that it's actually really helping her pain a lot. But all this, again, and getting back to this registration, how useful is this information? You can see if we use, this is just with 4 subjects, but using a nonlinear registration, there is a lot of overlap, but it doesn't tell you everything. And so I think doing individual maps is really important. The other thing is these maps are very reproducible. So this is other people's published work. This is our work showing that if you do these tractography, these thalamic segmentations over and over and over again in the same subject, you get the same map. So they're extremely reliable, which is important for surgical planning. But in contrast, if you look at it across patients, everyone's maps are different across patients. And so, again, emphasizing the need for patient-specific targeting. We can use this in a more innovative way as well. So the amygdala is a target that's been proposed for post-traumatic stress disorder. And I won't get into the whole but different parts of the amygdala have different patterns of connectivity. And so you can do this in somewhat of a blind fashion. So in the thalamus, we said, well, we know that different parts of the cortex of the thalamus might be connected. In this case, you can use your thalamus as an entire seed and say, OK, let's figure out where every single voxel goes. And then you look at the similarity of connectivity of each voxel. And you can we use k-means clustering to separate these out. And what you can get is a segmentation of the amygdala in a pattern that's actually very similar to what you'd expect from what we know about the functional and structure of the amygdala, so that we can target specific areas of the amygdala instead of just saying, well, we want to sort of go in the inferior region. We can actually get it to a meaningful area of the amygdala. So we can use tractography to investigate therapeutic mechanisms. And this is work from Jennifer Sweet and Cameron here at case showing that subthalamic nucleus stimulation, when it controls tremor, it's because of its adjacency to the cerebellar tracts that are ascending to the thalamus. And similarly, other groups have looked at the connectivity of pallidal stimulation to the thalamus and looking at its role in determining its role in controlling dystonia. I think the most interesting work is Cameron's that's come out is in depression patients. So, you know, I've made a point about depression. I think the group is very heterogeneous. I think the target is very difficult to identify also because it's just a white matter region. And so what they showed here is that people who responded had very specific patterns of connectivity. So you could go towards that concept that I showed in the thalamus where you say, well, let's find the region that shows the correct pattern of connectivity and target that region, which is very different than what neurosurgeons are used to doing right now. Right now, we're used to just looking at the anatomy and saying, well, I see that gyrus. I think I want to go right there. We need to be creating these maps that are based on connectivity and demonstrating targets. And it shouldn't be that hard if we know what the connectivity patterns are to create these maps for surgeons and for physicians. The last thing, another approach we've taken is exemplified here with cluster headache. So there's been a number of papers that have said that you can do deep brain stimulation for cluster, and everyone just calls it posterior hypothalamus. Turns out it's not the hypothalamus at all. It's posterior to the hypothalamus, but everyone's reported different targets, yet they all work. And so the thought being, if they all work, and deep brain stimulation works through a network phenomenon, then we should be able to look at what parts of the network are equally modulated by all of these targets and tell us something about what is going on in the therapeutic mechanisms. And basically what we did is we did that. We took several subjects. These are normal subjects, not cluster headache subjects. But we basically mapped out the tracks from every single target, and we looked at what was in common across all of them. And what we found is they were mostly projecting to the midbrain and cerebellum, which the reviewers didn't like because they said, well, it has to be the medial it has to be the frontal connectivity that's critical for this therapy. Except that, I mean, I couldn't make my results different than what they were. We can only report what they were. But I think that's, you know, I think this type of approach is important. And as I was discussing yesterday, so we have opportunities in Parkinson's disease, for example. We know that both subthalamic nucleus and GPI work. We can look at the connectivity for both of those targets and see what's in common and what's different, and try and understand our therapies a bit further in that manner. Okay, so now moving to the OR as a brain mapping laboratory. And the reason why I think it's important is because we can measure connectivity in the operating room, electrophysiologically, and it could actually be very informative. The other reason it's important, besides guiding our implant, is that if we can figure these out, we can move towards a closed loop stimulation system. Now, what we have now is closed loop, but physicians are closing the loop. We are the one who's assessing the patient and making the changes. What we want to do is get to a system where the loop is dependent on detection of certain states based on physiological parameters that then programs itself and is able to do this on an ongoing basis. And the way to do that is to record through our deep brain electrodes, which can stimulate, but they can also record. And what I do in addition in my operating room is when I have the burr hole open, I put electrodes under the dura so I can record from the cortex as well as the deep brain. And so now we suddenly have this opportunity to look at network phenomena. So we can look at bilateral. In our case, we mostly do GPI or pallidum. We can look at bilateral pallidum. We can also look at the cortex and now look at all these relations to one another. This work has been motivated in large part by studies like this, which was at the University of Minnesota, showing that the electrode pairs that have the highest beta power seem to be the area that you want to stimulate to derive good benefit from the therapy. There's also been studies, this is out of Spain, showing the spectrum in the subthalamic nucleus in an off state versus an on state. You can see when the patients are on, there's a very clear difference in the spectrum, which again tells you that we have a good biomarker, or a potentially good biomarker. Now, fortunately for me, not many people care to characterize the globus pallidus, except that we operate on the globus pallidus a lot. So we've done a lot of our work on the GPI. And this is an example of how we did our studies. So we have our DBS electrode. Instead of dropping it directly down to target, we advance it to this position, record for a minute during rest and movement. We advance it further. So now we've got those areas covered, and we advance it, and we advance it further and further. And then you can get a map of what happens as you get closer and closer to target. And what we see here is basically the spectrum as we move closer and closer to target. And you can see a clear difference as we get closer in. We get an increase in beta power, which you can see that the filtered signal here. So you have an increase in beta, low beta, high beta, and then this new band that hadn't been described in the globus pallidus before, which is as a 230 hertz signal, or centered at 230 hertz. What we see is, this is just graphically showing that those all increase. So it's a nice biomarker of where we want to go. And if anyone who's done microelectrode recordings, in my opinion, especially in the GPI, you can convince anyone in the room that you're seeing what you want to be seeing. Whereas this is, I think, a little bit more objective because it's clear that there's an increase in power here. There's no way to argue this and this, whereas a microelectrode recording can be finicky. I won't say they're completely subjective, but they're a bit difficult to interpret. It takes great expertise. What we also saw is these signals are movement modulated. So this 230 hertz signal, which hadn't previously been described, is clearly modulated by activity. So when people go from a resting state to a moving state, there's an increase in the power of that signal over time. And so this was our first exploration into the GPI and saying, well, actually, there's really interesting field potential signals there And there's actually more signals than we thought before. So there's been a great focus on signals less than 100 hertz. And I think now with modern recording technologies, we're really starting to explore these, in epilepsy, they're called the HFOs, or high frequency oscillations. But I think they're actually pertinent to other diseases as well, and they're not just epileptogenic phenomenon. We can take this a step further now. As I said, we put this ECOG strip over the brain with our deep brain electrode. We can then project this onto the surface and get an idea of where our electrodes are, map the structure with function. And looking now both at the DBS spectra as well as the ECOG spectra, again, you can see this movement versus, rest versus movement, clear differences in rest versus movement. So you get a suppression of beta with movement. You get an increase in this 230 hertz signal with movement as well. So we see that very clearly, consistently in virtually every subject that we record on. Here's our ECOG spectra, and this is focusing on our movement response. So there's only a certain contact that has the most response. But you see the classic beta suppression, increase in gamma with movement. So now we've got two interesting electrodes, both movement responsive, both presumably part of the motor network. And the idea is, do these relate to one another? So if they relate to one another, there should be some kind of relationship between the two. This is a little difficult to interpret. It basically just shows beta suppression. But the interesting thing is here is the coherence measures. So the GPI, the motor part of the GPI, which shows movement modulation, if you take that contact and you take the ECOG strip that has movement modulation, those show very specific coherence. So you know that you've identified the network, so you're measuring from this network, because those two contacts, if you look at the coherence measures, are significantly more coherent than any other electrode contact pair that you could look at. Moreover, that coherence is modulated by activity. When you move, you get a suppression of the coherence between these two regions, meaning that there's a loss of communication, in a sense, between the two. More interestingly, again, getting back to this idea of cross-frequency coupling, here's a cross-frequency coupling within the cortex. Phil Starr's group has published that you get high cross-frequency coupling in the motor cortex of patients with Parkinson's disease. And so we see the same thing, no question about it. We also see cross-frequency coupling between the globus pallidus and the cortex. So if you take this driving frequency from the GPI, you took the cortical signals, you have cross-frequency coupling between the deep brain and the cortex. So now we get into this idea of binding. So is these basal ganglion circuits regulating the cortical signals? What we do see is that with movement, these signals go away. So it seems to be a resting state phenomenon to be in this coupled state. Now the confusing thing, and this is where we have a lot of work left to be done, Phil Starr's group showed that if you take someone who's at rest, you stimulate them, this cross-frequency coupling goes away. So now we have two things that make cross-frequency coupling go away. You have movement makes it go away, and you have stimulation makes it go away. So it makes it a more complex network in terms of if you're going to use this signal, and a lot of people are now saying, well, that's what we need to use as our closed loop signal to drive our therapy. I would propose that it's actually more complicated because as soon as you move, the signal goes away. So it's not just a stimulation or a therapeutic mechanism. But the goal of all this is to basically say, this is what revolutionized Parkinson's management, which is that we said, OK, let's figure out a circuit model of what's going on in Parkinson's disease with loss of dopamine, and it guided our therapies. I think everyone agrees that this is a useful model, but it's oversimplified at this point. We understand a lot more. And what we have the opportunity to do through neurosurgery and through collaboration with engineering is to better understand this model. So not just say that there's projections and there's a decrease in inhibitory or excitatory signals, but actually say what's going on in a dynamic manner throughout this network, create this model more fully using both structural connectivity as well as this functional connectivity measures, invasive and non-invasive, and really get to a better understanding of this entire system. And the reason why we're focused on Parkinson's disease is not because we have a good therapy. We know we can treat Parkinson's disease, but it's a really good system to start with because we do know so much, and it is a good therapy, and we know that we can help people. So we have to understand it in a system that we know, and then apply that knowledge to systems that we don't know and develop newer therapies. So the conclusions from the invasive recordings is they do provide unique insight. There's high frequency bands that really do have important significance, and I didn't show it, but we have coupling between those lower frequencies and the 230 hertz signal as well. So there's a lot more information to be had. I do believe that the cortex seems to be gated by the basal ganglia thalamic circuits, and so this is basically a control mechanism gone awry, but we need to understand what that control mechanism is and how it's affected by movement and modulation. And really the future direction is to continue to do these recordings, ask important questions, and understand the circuit further. So I think my conclusions and future directions, I think integrating these measures of structural and functional connectivity really will help elucidate these mechanisms. It's a slow process. We were just speaking yesterday about the fact that industry really wants to push us really far ahead and basically say it's ready for prime time. We are ready to use these signals. We're going to guide our therapy based on this. I don't think we're anywhere near that, but we are as close as we've ever been, which is always true in science, but we need to do more work. And I think using these opportunities to correlate these non-invasive measures, which I think is ultimately what we need to do because we're not going to be doing invasive measures forever. This is just helping us understand how we can use our non-invasive techniques to guide our therapies and improve our treatments. The thalamus is really critical, but I think the whole basal ganglia circuit is critical. We can show between using these multi-modality approaches how structure constrains function, and there's really unique electrophysiological signatures that guide our therapy. Again, future directions, disease-specific approaches, so we need to make sure that we understand that everything we do is disease-specific. So unfortunately, with invasive recordings, we only operate on people with disease, so it's going to be hard to know what's not disease. But slowly but surely, we'll uncover that with time. One of the major criticisms of imaging is the spatial resolution. So diffusion tractography is at 2 millimeter resolution. If you're really good, you'll get at 1 millimeter resolution. The question is, how important is that? How much do we need to work on improving that resolution? Do we need to develop imaging modalities that get us better precision? And probably we do, but I think we don't need to work on that part of it until we understand what we need. So it's this ongoing battle between engineering and medicine, which is we can do things. Engineers can create things, but we need to know what's clinically necessary before we invest our time and capital into doing those things. Otherwise, you'll create something that's great, but it's not really useful. We need user-friendly interfaces, and my plea that I end all of my talks with is that everyone should collect DTI and resting state fMRI on all their patients because it's the only way we're going to understand things better. This university knows this much better than me. This has been a process that I've been struggling to deal with, which is to bring everyone at UCLA together who works in this domain and has interest. And we have made some progress, although it's going to take a lot more work. And then most importantly is everyone in my lab who does this type of work, who's helped me with all these analyses. My graduate students, Masa did most of this work, and Christos did as well. And then collaborators throughout UCLA. So thank you very much. Thank you. Questions? Yes.
So thanks for the very interesting talk. You mentioned there kind of towards the end about the phase amplitude coupling and these high frequency oscillations. I'm just wondering, based on your experience, what do you think might be the origin of those higher oscillations that you can record with those leads?
No idea. So the question was, what is the origin of those very high frequency oscillations at 230 hertz? I don't know. I mean, I think that's an ongoing debate. You know, in the epilepsy world, I think when it was just an epileptic or just specific epilepsy, well, people said, well, there's just these aberrant circuits that are producing. But now we're starting to recognize that it's not just an epilepsy phenomenon, and I strongly believe it's not, because we see it in every single one of our patients. So I don't know what generates such high frequency oscillations, but if anyone has any ideas.
Yeah.
There were 3 problems you mentioned of unknowns, the last one being the stimulation paradigms, which I missed. I wonder if you might actually give some comments on that and the way we're actually applying therapy.
So I think I alluded to it in that I think when we have our invasive recordings, so this idea of closed loop stimulation is where I think regulating our stimulation paradigms will come in. So if we understand the physiology, if we can have ongoing recordings that tell us about the state of a patient, that's where we can determine it. But what has to happen, and what we're doing in our operating room now, is basically recording signals, these physiological signals at the network level under different stimulation pairs. So changing the frequency, changing the amplitude, changing pulse width, and seeing how it changes the signals that we're recording. Eventually, once you understand that and its effect on therapeutic efficacy, you link the two and you modulate your therapy based on that.
That's sort of broader time scale modulation of the therapy, right? I'm just sort of adjusting parameters, but I'm wondering if there's any shorter time scale adjustment of parameters, or in terms of the information content in the, into the stimulus.
Well, I think, I didn't mean it to be broader. I meant it to be real. I think the data, this goes to the concept of right now it's really difficult and we have to do these broader data collections, but theoretically you should be able to get to a near real-time analysis of signals. So you have to understand, we have to understand how what we do perturbs the system or modulates the system sort of at this slow pace. And then understand how that can work in real time to get, so you need to know what your ideal state is and what your current state is and how the perturbations get you to that ideal state. That's what we don't know at all. I mean, we know a lot of, camera's really been the leader in the field in terms of figuring out, based on imaging, how we figure out the ideal stimulation parameters. But one of the challenges in what you've done is, and I think you recognize this, is that's a snapshot in time, and patients are dynamic, right? So they take their medications at different times, their medications level will go up and down, and that's why I think physiology is important as well. Am I answering your question, or am I avoiding it?
I can talk to you later. No, sure. I think neither, actually.
So, go ahead, yeah.
Go ahead.
Yeah, when you stimulate the GPI, do you use the same frequency when you stimulate the subthalamic nuclei? So is it coming about, you should try different frequency, because some of the oscillations in this network, okay, are really pathological. You want to override them. But,
Okay.
yeah.
To briefly, stimulation is roughly at the same frequency, but I think the idea of optimizing the stimulation frequency is a good one, and it may be that selecting the, based on the patient's physiology might be appropriate. But generically, the neurologist can actually answer this question better, but the stimulation frequencies are roughly the same. They're not hugely different. It just depends on each center. So some centers might be the same, some centers might not. But I think what we do need to do in our experiments is stimulate at different frequencies and see how that modulates the system and how it relates to the patient's intrinsic signals. So.
All right, I guess that's